We have a few questions here in the chat rooms. So one is from Dr. Prakasit from Thailand. The question is to Dr. Aaron, is how much tension do you put on artelon?
Okay, that one is actually quite difficult. What I do is I stretch it fully in the knee, on the tibia side. I pull it as hard as I can, and then I will then let go 50%. And usually that's the tension I use, because I'm not sure whether there's any data or dynamometer that you can actually claim that this is the correct tension for artelon. I don't think anybody has ever done that, but usually I will pull as hard as I can, maximum, and let go about 50%, and then I'll fix it in that position with the knee straight.
So Dr. Aaron, do you experience any like stiffness if you over pull the artelons?
No, none. Because it is elastic, it will give a bit, so it's all right. None. So far, I've not had any stiff knees.
I see. Dr. Prakasit, do you have any further questions on these topics on the tensions? You can voice, Dr. Prakasit.
Yes. Can you hear me?
Yes.
Okay. Normally I use my own implant fix of Johnson & Johnson to fixing the tibial side. It has a tensioning device that can tension the graft, but the limitation is all 4 strands of graft must have the same tension. So what is the recommendation for using the artelon with this tensioning device?
I see. So basically, Dr. Prakash is using a J&G tensioning device when he put a screw in.
Yes.
Yeah. No, I understand. I understand your question. The answer is we don't have data. You really want a specific tension of whether it's 10 newtons or not. We do not have data at this time. We've just started using this for the last year. These are all the things you have to work out, because nobody, I'm not sure that internationally, I don't think there's enough data to tell you that how much tension to use. I really cannot answer your question because we don't have the data for this, for tensioning. I'm not sure whether Aaron Smith has any. Okay, can we pass it over to Aaron Smith? Maybe you can tell us.
Yeah, I could just quickly add something that may help with this decision. So the stiffness of these artelon strips is actually less than the stiffness of a native ACL ligament. It's about 50%. So what that means is it would be difficult to over tension it. You know, you can apply quite a bit of tension and the strip will still be less stiff than a normal ligament would be. So it is very forgiving. There's different methods to do the tensioning. As Dr. Aaron pointed out, some of that's the art of the surgery, right? It's, feeling it. When you feel it in your hands and you feel the stability of the knee, you can make some decisions about it. But it's intentionally designed to be safe, to be less stiff. So it's very difficult to over constrain it.
Thank you, Aaron.
Sure.
Prakash, is it
Another thing, can I ask about the shoulder surgery?
Shoulder, okay.
Yeah, I saw the presentation of Dr. Gan. He said that he do the ACR with this artelon tabs, right?
Yes.
Mm-hmm.
How about the result?
I mean, the patients, basically, the ones that I've done have been there for the last 2 months. Results, you see, don't forget, we are all feeling our way with artelon at the moment, because I've only had it for less than a year. So for SCR, I've done 3 patients for in the last 2-3 months. What I like about it is that the SCR is done and the rotator cuff tear is repaired on top of it, and I can move the patient straight away. I'm not afraid of moving the patient because I know I have a nice graft in there. So mobility is early. I move them very early instead of putting them in a brace.
But you didn't use any autograft, right?
No. No, there's no autograph. It's basically you fold over the artelon in, and then you put it as an SCR, and then you repair whatever you can of your rotator cuff on top.
Okay. That means put the artelon underneath the.
Yes, because you want it next to the, because you have to get to the glenoid. So it's underneath.
Okay.
Yeah.
Thank you.
All right. So we have next questions for Dr. Gan is for your hybrid graft in ACL, you use a semi-T or a gracilis to combine with the artelon?
I routinely use semi-T because the size, I actually triple my semi-T, right? And then you put the artelon, you will get a graft that is more than 8 millimeter. So I do not get a graft less than 8 nowadays. So you will get an average of like between 8 to 10, right? Normally. In ladies, you probably get 8, right? In men, you get about 10. So sometimes you get 11, right? So as you get bigger, right, I triple my graft, triple my semi-T. Gracilis, I think is too small, right? You can try, but you will get a size like about 6. Your artelon actually increase the size when you put it in to about 2 to 3 millimeters. So if you have a graft that is 7, right, you get somewhere about 9 or 10 like that, right? If you triple your graft, but if you put it two gracilis and all these things, to triple gracilis is too short, so you can't triple a gracilis properly. Right.
I don't like I don't like tripling semi-T. So what I do is I use semi-T and gracilis and artelon, and I have never had anything less than 8 mm diameter grafts so far in the last year. So
having said that, right, we actually that study that we did is both racing. So you're actually going to risk a bit of like loss of power, especially your hamstring, right? So that's the reason for doing a triple, to cut down mobility, right? So if you are athlete, if you have a hamstring that is weaker, hamstring is supposed to protect your ACL. Right. So if you have a weaker hamstring, then you are putting your ACL graft at the risk. So there's a lot of argument on this.
So I have a very funny question now when I promote artelons to replace one of the hamstrings, just to harvest one. I tend to promote artelons which can replace, you can just only harvest one hamstring instead of 2. But the surgeon's feedback is, since I'm already opened the incisions, I'm harvesting 1. Why not I just harvest 2? Does it make effects if I harvest only 1 instead of 2 hamstrings?
That's the whole thing about the study. We actually saw some patients actually lose almost like 30% of their strength even when they come back. Some of these 50 patients that we see who had semi-T and gracilis coming back, they almost lose almost like 30% of their strength, right? So as you see, the funny thing about hamstring is that it's a muscle that you don't look at a lot of time. You don't work out. Even if you go to the gym, you tend not to do your hamstring as much as your quads. You like to do the extension exercise, but the curl you tend to not do. So there's actually up to 30% weakness, right, that we see. So that's why we were observing this. We were a bit alarmed at some of our patients. And those patients who comes back for revision had artelon alone, there are 6 of them that we do at them. Their hamstring is like 25 to 30% lesser. So what we are worried is that because of the hamstring being loose, their ACL graft that you have done is actually being under strain because your hamstring is not protecting it enough. So I think right, so taking 2 may not be a problem at that time. So in the long run, it may cause a bit of issue as well. So that's what we are trying to establish here in the study.
Thank you, Dr. Gans. I think your answers my questions very well. All right, we have another question for Dr. Gan is, do you put tensions on artelons for MPFL reconstructions?
Well, MPFL, you have to be a bit careful how much tension you pay, because you're only going to use the artelon as the only graft if you so you can over tension. Having said that, because it is very forgiving, right? I actually over-tensioned a few of my patients. Out of the 6 patients that I did, no, 5 patients that I did, actually we over-tensioned. And then they have post-op clicking because of the over-tensioning. But over 6 weeks, the tension, the sound actually goes off. So I'm a bit worried about the patient, but actually on following up, now the patient is starting to run at 5 months, right? So without any pain, right? So I think over tensioning may not be as bad in artelon as compared to if you use a semi-T graft and so on, right?
I absolutely agree with that.
Right. So you have to play with the tensioning a bit.
Great. All right. Thank you, Dr. Gant. So do we have any questions, any more questions? And I believe actually inside today's group, we have some others artelon users, Malaysia's artelon users here. Maybe you guys can share your experience on artelons. Like Prof. Jamal, I see you. Hi, Prof. Jamal. Would you like to share your experience on artelons?
Hi. I've used, but I don't use that many. But I find it very forgiving. And in terms of tensioning, I just tension as when I use for tensioning the semi-T, the hamstring. I don't release like what Dr. Aaron said, release by about 50%. I just maintain at the same tension, and they have a bit of tightness in the beginning, but it all go off with the physiotherapy. And usually I find it I can mobilize much faster and off their crutches very early. And some of my patients off their crutches and use just the brace for after 1 week.
Overall, good results for that patient, is it, after artelon?
Yeah, the only thing I find, but it's a bit unfortunate, my first case that I used was I used just purely this artelon for my ACL and PCL reconstruction in a dislocated knee, but
yeah,
unfortunately it got infected, and I find that you have to mobilize them very early, otherwise the stiffness set in very fast.
right.
And unfortunately this patient are a bit lazy and doesn't want to stiff. We control the infection, but the stiffness were to go on.
Right, all right. Thank you, Prof. Jamal, for your sharing. Thank you so much. Aaron Smith, actually, we Malaysians, we promote artelons a lot in the sports medicines, arthroscopies. So we rarely use artelons in foot and ankle yet. And we notice in the States, artelons been used a lot in the foot and ankles. Maybe you can give us some ideas what is the best case to use in foot and ankle?
Yeah, sure. So it's interesting if you look at outcomes, long-term outcomes for lateral ankle instability, you find similar trends as you find in the ACL and the knee. I think it's a much worse injury than many people have believed. Generally speaking, over a 10 to 12 year period, of all patients that have surgery for a lateral ankle instability, about 1/3 of them will require a second surgery sometime in their life. About 2/3 of them have recurrent pain or instability, and about 80% of them will develop arthritis in the ankle over 10 years. So, the traditional procedures, the most common here is the anatomic reconstruction, a rostrum repair, which is, just really reconstructing the local tissue, which is often attenuated and weak and not that structurally sound. So the most common procedure we do here is using artelon to augment a rostrum reconstruction of the lateral ankle for the same reasons that you would use it in the ACL. And we've seen very good results. We actually have a randomized controlled trial that's been completed, hasn't been published yet. But that is the largest area of interest for foot and ankle surgery in the US. Another common application is Achilles tendon. For those of you who are football fans, you know David Beckham, the English player. He actually had his Achilles reconstructed with artelon back in, geez, I can't remember what year, 2012 maybe. That was unfortunately the end of his international career, but he was an older fellow by then. But they shipped him off to the United States and let him play soccer here. And he won the championship the following season. So he had a very good outcome. Typically when we're doing Achilles reconstructions, they'll use the strips, the same bands that you would use for the ACL. And you can go through the proximal stump of the Achilles and then do a box repair through the distal stump, tension it back to itself. It provides additional strength and elasticity to that repair. For insertional Achilles, you can actually take those strips down to the calcaneus and insert them into the calcaneus with interference screws. So those are very commonly done, and we have some good published data on Achilles as well. Outside of that, we do spring ligament for adult flat foot deformity. You know, we have a larger patient population in the US. We have many obese people, you know, diabetics, smokers, people with healing difficulties. So spring ligament disease is very common here. Posterior tibial tendon reconstructions, and then traumatic injuries, deltoid, anterior tibial tendon. Those are the most common applications.
Aaron, may I ask you, we are okay with the tension. How about interference screw on the artelon? Does it disrupt the compression? Does it disrupt the fibers and so on?
Yeah, you have to be a little bit careful. You know, it's not like a piece of suture tape where it's very strong and very durable. It's made to resemble a ligament. It can be damaged if you're not careful. Typically speaking, what we find works the best is a line-to-line fit between the tunnel and the interference screw. So, you know, if you're using a 6mm screw, do a 6mm tunnel, maybe a little bit oversized. The fixation with artelon is generally quite good because it is so compressible and it has a little bit of a tread like a tire. So it has very good grip against the bone. And that's independent of bone quality. You know, you mentioned MPFLs, you know, typically the patella is quite soft, but even in soft bone, you have good resistance to pull out. So I think the key is just not to be too aggressive with your fit. You know, if you have a very tight tunnel and a very big screw, you could damage the artelon.
So, Dr. Gan, is it all right?
Okay, so I will not put a big screw like Dr. Aaron.
I don't use the big screw, same size as tunnel.
You put size bigger sometimes.
Yeah. You know, the other thing that we saw in the histology is that even in bone tunnels, that artelon material will integrate very quickly. So unlike a biological graft where it will get weaker and weaker over those first 12 weeks, the fixation to the bone will actually increase in strength, you know, pretty immediately following surgery.
What I actually do, because of this fear of cutting, right? I have bad experience with it, even with the autograft. I do put ankle sutures there. I actually suture artelon into the hole. I bury the ankle, so try to bring it in as much as possible. That give me more peace of mind.
It's a good practice, yeah. What we commonly see here in the US too is people using press fit anchors rather than screw in anchors, because the press fit, you just tap them straight in and there's nothing sharp running against the fibers.
Yeah. Okay.
Aaron, for the foot and ankle surgeries, is it recommends to put the artelon inside the bone, or can we just lie the artelons on top of the bone instead of just suture anchor it in?
You can do either. We've seen both techniques. Both are common. Both yield good results. You know, both you'll see good integration. So it's really surgeon's choice.
Right. Thank you, Aaron.
The incorporation into the bone is faster, or to the soft tissue is faster? I'm quite sure it's the bone will be faster.
Yeah, I think it's faster in the bone because it's more vascular, but it's also, immature tissue, right? So it'll be fibrous tissue for some period of time. You'll see some slow increase of strength until that bone begins to mineralize and mature.
Thank you, Aaron. So we are almost we are 1 hour. So maybe another last questions for anyone before we end today's. Anyone? Dr. Tang, do you want to share your experience on the artelons? Dr. Tang? Dr. Tang, you can hear me?
Yeah. Can you hear me?
Yes. Dr. Tang, you're using quite numbers of artelons. Any tips and pearls that you want to share to the audience for today?
Yeah, I've done quite a few, but then I don't tension it at all. I don't know don't know which one is wrong or right. But then what I do is I actually secured with suture to the hamstring graft, secure tightly, entirely incorporated into the hamstring graft, so that it won't run away, and I have no worries of my. I actually hide it under the hamstring like Aaron did, and then I don't tension it, and then I put the bio screw through it without worries. All
right. So how is the outcomes? So do you find the patient's recovery is much faster with artelons?
Yeah, I said, I'm quite happy with the result. So far, they return to sport faster, and there are less chances of, I don't see them, you see, with the pure hamstring, it's always after 1 year when they go back to play, when they go back jogging. Sometimes with pure hamstring, you can see occasional patient, they rupture their graft. So far, I've never ruptured any graft and with this one now. So I think it's good, yeah. Certainly add more confidence.
All right. Thank you, Dr. Tang. Thank you for your sharing. So without any questions, we will call this a day. All right.
Jeff, if I could just quickly thank Dr. Aaron and Dr. Gan for their early experience with artelon. I'm always learning, and I appreciate the work you've put into it and hope to continue to collaborate. Thank you.
Thank you, Aaron. Thank you, Dr. Aaron and Dr. Gan. Thank you, everyone, for your time. Thanks. Bye-bye.
Bye.
Bye.
Thank you. Bye-bye.
Bye.